Morning, Dr. Sadiq.
Kapoor. Morning.
So who's the? Okay. So students, volunteer. We have Dr. Sadiq Sikora, who is now the Chief of Surgical Gastroenterology at Sikora Hospital in Bangalore. Earlier, he had a long stint at SGPGI with me as a faculty colleague. And as most of you would know, he's one of the leading experts on management of bile duct injuries and repair of biliary strictures. With a very large experience and deep understanding of the subject. So, start shooting questions.
So before that, Dr. Kapoor, thank you very much for inviting me. I hear that this forum is becoming very popular, and with the way I'm seeing your leadership in this, which is well known, of course, I see that a lot of people are going to benefit by these sessions. So thank you for having me on this session.
Thank you. So students, either you can raise your hand and ask, or put your query in the chat, then Dr. Sadiq will take it up. So who are the exam going? Let me see if I can see some known names, then I can ask them. Raghav, you are there. You presented a case last time, isn't it?
Yes, sir. Good morning, sir. I was just typing my question.
Yes, yes. Come.
Yes, sir. Good morning, sir. Yes,
Put
sir.
your video on. Come on the screen.
Yes, sir. So, is my video visible, sir?
So let's start with the timing.
Okay, sir.
In your opinion, what
Yes,
is
sir.
the best time to repair a bile duct injury?
Sir, best time I think would be if it is detected on table and expertise is available, and it is an also depending on the type of injury, how the injury occurred, and the condition of the patient. I think a late repair is always preferred if detected in the post-operative period, but almost 1/3 of injuries are detected on table, and depending on the type, we can also go for a intraoperative repair if expertise is available on table. And there is no associated arterial injury, sir.
Yeah. So, Dr. Sadiq, any comments on that?
So Raghav, I mean, the point is well taken that whenever you have an injury detected on the table,
yes, sir.
the best option is to do an intraoperative repair.
Yes, sir.
But it has to sort of certain caveats have to be fulfilled.
Yes, sir.
And that is the key element in this, and which a lot of people forget.
Yes,
So
sir.
the first and foremost, most important caveat is what is the setup and the expertise available.
Yes, sir.
If that is fulfilled, then we go on to the next step. So if you don't have the expertise, the setup is not geared to do a major surgical repair at that point of time, then it is clear that it should not be repaired.
Yes, sir.
Once you have the expertise and people available to repair the injury, then
Yes,
you
sir.
have to have a complete assessment of the injury. And the complete assessment entails two things. One is a complete cholangiographic delineation of the extent of injury.
Yes, sir.
And the second, as you mentioned, is a
Intraoperative
vascular
ultrasound.
injury if it is associated.
Yes, sir.
So these three caveats have to be completed before we say that early repair is best.
Yes, sir.
And if these are completed and it is a favorable injury without vascular injury, then certainly the best time to repair or injury detected on the table is at that point of time.
Yes, sir. Yes, sir.
But what about repair injury which is presented to you, say, a week later?
Sir, I think if an injury has presented to us a week later, then we should evaluate the patient thoroughly. Also check for his general condition first, his vitals, and try to talk to the operating surgeon if possible. Intraoperative findings, if can be ascribed from the data, and why the procedure, the indications, and any preoperative imaging is available. And if possible, the intraoperative unfortunate event and that occurred, talk to the surgeon, histopathology if available, check for his investigations if all these are within the normal range, and try to go in for a late repair, especially if there is an associated arterial injury, because it tends to the level of the and try to manage the patient. Like if there is sepsis, treat the sepsis. If there is undrained collection, we should go in for draining the collection and stabilize the patient. And if finally the injury gets converted into a stricture, benign biliary stricture, and then we finally try to go in for a late repair, that is preferred. Up till 72 hours, early repair can be done. Beyond that, results have shown that a late repair has better results than going in for an intermediate repair after thorough investigation of the
Better
patient.
way, this is a very broad question which Dr. Sadiq asked. So first you should give the broad outline of management rather than going into specific details that I will check
Yes,
the
sir.
pulse rate and all. So a better way to answer this question would be that 1 week after the injury, there is a high possibility that there is a bile leak, myeloma, sepsis. So in presence of sepsis, repair should not be done.
Yes, sir.
So the better way to answer this would be that I will look for evidence of bile leak, bile collection, biliary and peritoneal sepsis. And if it is there, then in that setting, repair is not indicated. And then you would, as you rightly said, you would drain the bile. The aim is to convert the acute bile duct injury with bile leak into a controlled external biliary fistula. Let the fistula close, stricture form, stricture mature, and then do what is known as a delayed repair. The only exception to this would be if it is a completely clipped or ligated duct with no bile leak in the peritoneal cavity, no biliary sepsis in the form of cholangitis. Bilirubin is rising very rapidly. You do an ultrasound or a cholangiogram, MR cholangiogram, you see good dilated ducts, and it is a favorable type of stricture, which means bismuth type 1, type 2, or a good type 3, as we have described when Dr. Sadiq was with us in SGPGI. We said that type 3 strictures also can be good or bad, A and B. If the confluence is well forming, there is a good confluence, both the ducts are joining and the diameter even at the confluence is same as the right and left ducts, then it is a good or a type 3A stricture. On the other hand, if you see two dilated ducts and there is just some communication, very narrow communication, then it is that the stricturing process has involved the floor of the confluence, which is a bad type 3 stricture, what we call type 3B. And we said that in terms of technical difficulty, operating time, and results, this behaves almost like a type 4 stricture. So that is what we said. So if it is a good anatomy and all the other conditions which are fulfilled, plus you do an angiographic or a Doppler evaluation and show that there is no vascular injury, then as an exception, you may do repair even at 7 days or 14 days or whatever it is. But the main issue is presence of bile leak and sepsis. Yeah, Dr. Sadiq.
Oh, yeah, I mean, absolutely. So, Raghav, your answer should have been the reverse way. What you said in the end has to be before. That presentation, if somebody tells you at day 7, the key is what is the presentation of the patient? The presentation is bile leak, bilioma, sepsis, then that takes precedence over repair. If the presentation is with jaundice, and as Dr. Kapoor said, with no evidence of sepsis, good favorable anatomy, and patient is in good general condition, ready for repair, that is a situation where you may do a repair even if it is day 7, day 10 or whatever. Those are not very common clinical situations that we encounter, But that is one exception in which when the injury is presenting late, you may consider repair at the time of presentation, provided again, see, what you have to remember in timing of bile duct injury, there is nothing which is right or wrong. It is the caveats which are associated with the repair. And you have to always tick those boxes and make sure it is in the favorable range or the unfavorable situation. If it is favorable, so presentation, expertise, anatomy, vascular injury, all those is favorable, then it can be repaired. If it is unfavorable, then you need to delay it, and there the management priorities are control of sepsis, control of bile leak, make it a controlled fistula, and so on and so forth. And then eventually undertake surgery. Again, the subsequent timing, there is no hard and fast rule that after this period only, but generally we presume that 3 weeks to 4 weeks is a good enough time for all sepsis to resolve or inflammation to improve and the ducts to be in the best condition for us to undertake this safe bilioenteric anastomosis.
Manik, can you come in? So how do you prepare? Suppose we have an established biliary stricture and we are wanting to operate. Let's go on to the hepaticojejunoscopy. How do you prepare a patient? What specific preparation would you do? Manik, Yadam? Come in. Manik, are you there? Unmute yourself. Rohit, you are there? Who wants to
Anybody else wants to take it?
Who wants to take this question? How do you prepare a patient with biliary stricture for surgery? What specific preparation is required? It is better that you give a wrong answer here than in the exam. So come in.
Good morning, sir.
Yes. Okay. Okay, sure. Come. Yes.
You have muted yourself again.
Sir, am I audible?
Yes.
First, I have to prepare the patient should be sepsis free. And I have to know the nutrition state of the patient, the performance state of the patient. And I have to know the lab parameters, like all the routine CBC, LFT, and also RFT, and including the INR. And also know the biliary anatomy. So I have to go for
Hold
MRCP.
on. You did not see, you must listen to the question properly. I asked what specific preparation. So don't mention anything which you would do in any other case. I want to know what specific preparation is required when you are operating on a patient with benign biliary stricture. So go back again.
Sir, I want to know the biliary anatomy.
So how do you do that?
So MRCPs.
I would like to assess the complete biliary anatomy, which is best done today by a magnetic resonance cholangiogram.
Yes.
Okay, next.
I want to know the vascular anatomy and also to rule any portal hypertension. Based upon the
vascular anatomy is important in biliary stricture repair. When you say vascular anatomy, you mean apparent anatomy?
No, sir. I want to know about the portal hypertension, splenomegaly, and also any secondary biliary cirrhosis.
So that is not vascular anatomy, that is vascular pathology.
Sorry, vascular pathology, not one.
Yes. So you want to know whether there is portal hypertension.
Portal hypertension. Yes, sir.
In every case?
No, sir. Duration of from the injury to stricture means if more than 6 months, I want to know whether he may turn into a secondary biliary cirrhosis.
Yeah. So better way to answer this would be that if the stricture has been there for a long period, it is an arbitrary figure, 6 months, most groups follow that. if there has been biliary obstruction for a long period, say around 6 or more months, then there are chances that patient may have developed. See, when you answer a question, you should show your complete knowledge. Don't give one word or one phrase answers. Say the complete thing. So I want to know whether the patient has developed secondary biliary cirrhosis and subsequent portal hypertension. So how would you do that? What would you do?
Sir, use your abdominal Doppler. And
Okay,
upper
so
G
you would like to
endoscopy.
do a Doppler study.
Yes, sir.
Anything else?
Upper G endoscopy.
Upper GI endoscopy. Okay. Next, what else? Specific preparation.
I will arrange blood. Sir, need of blood is there.
What is the commonest presentation of these symptoms they present with?
Sir, jaundice, sir.
Jaundice. So any specific preparation required for jaundice?
Yes, sir. Preoperative biliary drainage. No,
All
not
patients with jaundice?
No, sir.
biliary-
Patient. No, sir. If patient has cholangitis, then only I will drain.
So then why mention that you will do preoperative biliary drainage? What is more important, which will be done in almost every patient with biliary stricture who is presenting with jaundice, is that you look for coagulation profile. That is a specific preparation. And if there is coagulopathy, and in fact, most groups, even if there is no coagulopathy on investigation, would give 3 to 5 days of vitamin K to these patients, presuming that they will have some coagulation disturbance because of biliary obstruction and vitamin K deficiency, isn't it?
Yes.
So that is a specific preparation. Now coming to preoperative biliary drainage, do all patients with biliary stricture who present with jaundice require pre-op biliary drainage?
No, sir. In high strictures where there is a difficult to identify the ducts intraoperatively, this is the one. And second thing, it's not preoperative biliary drainage only for cholangitis, sir. One is for cholangitis,
Yes.
uncontrolled cholangitis. Second is pruritus, severe pruritus, not release medications.
If you are not going to operate in a few days, if you are going to operate in a few days, then that also is not an indication. So by and large, uncontrolled cholangitis is the only indication for preoperative biliary drainage in biliary stricture. Level of bilirubin is usually, most groups would not do biliary drainage just because the level of bilirubin is high. Dr. Sadiq, any point on that?
Yeah, so see, again, you always have to, when you're thinking also, you have to organize yourself in a particular manner. So you can always see that any issue or question which is raised in this manner has 2 or 3 components. The first component, of course, is the patient, right? Second is the disease component. And the third is, generally for surgeons, it is the anatomical component. And especially in this situation, it's very important. So patient is important. So that means patient, as you said, it is important to know the interval between the injury and the presentation, because that determines your thought process in terms of what are the possible complications which could have occurred in this period, and you have to be aware of that. So the longer the interval, injury presentation interval is, you look for chronic problems, which is nutrition, coagulopathy if the patient has jaundice, or a bile loss if the external biliary fistula. So nutritional status of this patient, and of course comorbidities if any of this patient, which has to be prepared. So when you are preparing this patient, apart from sepsis, coagulopathy, what you need to, if the patient has jaundice, then this patient will have a specific preparation of ensuring good hydration for this patient, renal functions to be checked for this patient, and so on and so forth for patients with jaundice. If the interval is long, as you correctly said, you may want to know whether there is secondary biliary cirrhosis which has set in. Generally, anything beyond, we have seen that even as early as 3 months following an injury, you may have secondary changes in the liver and portal hypertension. So anything beyond 3 months, you have to be aware of that. And what you can do clinically, you look at spleen. if it is palpable, liver if it is enlarged, and then of course Doppler study, ultrasound which tells about the spleen, and if spleen is enlarged and if there is a high degree of suspicion, prolonged duration, then certainly an upper GI endoscopy will be required. So this is about the patient preparation. So sepsis, coagulopathy, jaundice in terms of hydration. Then we come to anatomy, which in a benign biliary stricture, especially post-cholecystectomy as we are talking about, is very, very important. So as you said, we need to do a MR cholangiogram, which is the best means of assessing the anatomy at present that we have. You have to be also clear that how you will look at this MR cholangiogram. You have to be able to look at these not static films, but should be able to work on the desktop or the workstation with the radiologist to look at the cholangiograms both in the axial and also thin cuts, reconstructions, and in various rotations, because sometimes a particular image may not give the correct picture. You have to also remember the worst picture that you see is what you should accept as the perhaps the real scenario of the biliary stricture. Sometimes with overlap of ducts in a particular view, you may be misled into under-reporting of the extent of injury or type of stricture. So you have to be aware of that. Along with it, with MR, you can get all other information also. You can get vascular information. If you really need, you can do a contrast MR. You can look at the spleen in that. Liver, you can also have an assessment of that in terms of how the liver is looking, whether it is nodular, whether there are any cholangiotic abscesses. So there is a lot of information which you can get in this MR, which you have to be clear about. And once you do a complete assessment of the anatomy, then you know what is the approach you have to take for this repair, whether it is a difficult repair or an easy repair. There are no repairs which are easy, but in terms of anatomical access, you have to get this information. So I would say this is how you would assess comprehensively a patient who's presented with post-cholecystectomy bile duct injury beyond the early injury.
So, any other student? Kiran, you are there? Any special preparation required depending on the type of stricture, the level of injury? Anybody? Any student would like to comment?
While somebody is thinking about that, I just want to also...
Govind has put a comment. Govind, why don't you... Okay, Raghav has raised his hand. Raghav, comment. Yes. So you want to take that question?
Sir, okay, sir. For a higher, if there is a high level of injury, then definitely I would like to also go in for a MR angio to document if there is any associated arterial injury, and be aware of against doing an early repair at any cost. And also in the higher strictures, I would just one day before, I would like to do a catheterization, PTC. Sometimes the hilum is frozen, sometimes there is atrophy, hypertrophy complex in the high strictures. So it is difficult to identify the biliary duct intraoperatively, as it tends to, due to the anti-clockwise rotation, it tends to go posteriorly. So in those cases, I can put a PTC and use it as a guide intraoperatively to identify the duct. Also, in the aberrant ductal injury, sometimes we may have to go in for a drainage preoperatively, as it does not communicate with the main system in cases of cholangitis or abscesses, cholangiolitic abscesses that are being formed in that segment. So in those cases, drainage may be required. Also, detecting the biliary ductal anatomy is imperative, that so that essentially all the segments are drained when we go for a definitive repair. And
yeah.
So why do you need a arterial anatomy in a high injury?
Sir, mainly for the purpose of documentation that there is if there an injury has taken place pre-repair, because sometimes during the repair, complicated repair, the injury can take place. So for medical legal purpose, I would like to document the same. Also, that would, although I am going in for a delayed repair only, but that would be more strongly favoring my decision of delayed repair, because the level of the injury tends to move up as time progresses in arterial injury. And also in the rare case, I'd also like to demonstrate an extreme biliovascular injury, if any, or the concomitant portal vein injury, if any, that is there, and have it on record.
So again, early injury is different. There you would want to know, that I agree. For purposes of repair and results, the presence or absence of here, when we are looking at it, is arterial injury only.
Yes, sir.
When we are talking about vascular injury, predominantly is the arterial injury. It really doesn't matter whether there is an arterial injury in a delayed repair, because the stricture has matured. That's what you would hope, that when you're choosing to repair, it is adequate time for the stricture to mature, and whatever the consequences of this vascular injury has manifested itself by this point of time. Usually what happens with an arterial injury? Arterial injury usually doesn't cause atrophy, hypertrophy. That usually happens with biliary injury and also portal injury. So arterial injury predominantly leads to ischemic presentation of the biliary ducts, and that is why you need time between injury and repair, so that the stricture matures. Once there is adequate time, and what is that adequate time? I would say anything beyond 3 months. If there is adequate time, the stricture is matured, you don't expect that the arterial injury would influence the results of your repair, what you choose to do based on the anatomy. But I take your point that for medical legal documentation, if you need to do, which is a little far-fetched argument, but it's okay that, for that purpose, you may document whether there is a pre-existing injury or not. In certain scenarios where there is a continuing bile leak, where there is associated vascular injury, and it is enough time has been given beyond that, or where there is atrophy, hypertrophy, in those situations, you may consider a hepatectomy if there is associated vascular injury. So that is a very select group in which you may want to consider hepatectomy during the primary repair of a bile duct injury. Then you would certainly want to know the vascular anatomy in that situation. So I just wanted to make this clear that vascular injury is important, has relevance predominantly in early injury. It has its consequences subsequently, but it does not have any bearing in long-term outcome following a delayed repair of bile duct injury. Other points which you mentioned, I think all are very relevant, and you have really addressed the issue about preoperative biliary drainage, which Dr. Kapoor had asked earlier also, that the only indication of preoperative biliary drainage, I think the earlier speaker had addressed this, is sepsis. And or in a very rare situation where there is very high jaundice, patient has associated comorbidities, coagulopathies, which are poor nutritional status, which makes the repair undertaking a difficult exercise in terms of associated comorbidities. In that situation, you may do that, where even if there is no sepsis. But that is not very common, and so the only indication would be of preoperative biliary drainage is sepsis or cholangitis. And what you said about response to Dr. Kapoor's question about the preoperative biliary drainage or catheterization, immediate pre-op for difficult strictures. I think I agree with all the situations which you mentioned, which needs catheterization so as to identify intraoperatively the ducts to ensure, you in the passing mentioned, but I think that is a critical step in the repair of bile duct injury, which is to drain all ducts. And that's our responsibility, to ensure that all ducts are drained when you undertake a repair for benign biliary stricture or post-cholecystectomy injury.
So students, for your exam as well as tomorrow when you become a consultant, the basic principle is complete delineation of the biliary anatomy, which is today by an MR. And as Dr. Sadik said, you have to see it in different rotations and be prepared for the worst case scenario. And second, that all ducts have to be drained. Now, if there is a favorable anatomy, then you drain the confluence and the left duct, all ducts will be drained because they are all communicating. But if you have a difficult, a complex stricture in the form of type 4 or type 5, an isolated duct, then it is a must. I underline that word. It is a must that the difficult ducts, which are usually on the right side, have to be cannulated. Now, this is different from PTBD. PTBD is drainage, which you do for uncontrolled cholangitis. So, if there is uncontrolled cholangitis, you drain and then you wait roughly around 10 to 14 days time once the sepsis is completely settled and then operate. The second one, which you do for a difficult stricture, difficult anatomy, is catheterization, cannulation, which you do just the day before or even in the morning of surgery, done by your interventional radiologist. So you see the anatomy. If the right anterior and posterior are joining, then you cannulate only one of them. But if unfortunately they are also separate, you may have to cannulate both of them. If it is an isolated stricture which you are going to repair with or without main duct stricture, then that isolated duct has to be cannulated. And what you request your radiologist is to pass the catheter as far down, as close to the hilum as possible. And these catheters will then help you to identify the duct intraoperatively. Either you inject saline, or you inject methylene blue, or you do a formal intraoperative cholangiogram, or you do an intraoperative ultrasound and see the catheter inside the duct. And then you can use these catheters as transhepatic, transanascomatic stents. We will come to that later. So there is a difference between biliary drainage and biliary catheterization or cannulation. And again, I would repeat, if you are going to repair a difficult stricture, have the difficult ducts that is on the right side cannulated by your interventional radiologist. Now, Govind has raised a point about if you are thinking of a possible hepatic resection. Govind, can you come in? So can you tell us what will be the indications for hepatectomy in a biliary stricture or bile duct injury?
Sir, good morning, sir. Sir, actually, in an isolated stricture, like if the stricture is extending intrahepatically, or there is segmental calculi in the setting of a biliary stricture, intrahepatic calculi and long strictures, these may be indications for hepatectomy, sir, hepatic resection, or if there has been segmental cholangitis which persists even after drainage. And also in case of chronic cholangitis with atrophy of the liver segment due to stricture. So atrophy hypertrophy complex, intrahepatic strictures, intrahepatic calculi are various reasons which due to which we can land up in a hepatic resection intraoperatively.
Dr. Sadik, would you like to refine the answer for the sake of students?
So I think what we should look at hepatic resection in two scenarios. One is in acute biliary injury. Now there in acute biliary injury, it is a scenario which may present like a high bile duct injury with associated vascular injury, say a right hepatic artery injury. Now in this scenario with the small ducts and multiple ducts, it may be a difficult situation to repair these injury, and in that scenario if you're doing a primary repair, if expertise is available, and you know that there is an arterial injury along with a high confluence injury, you can elect to do a hepatectomy in this situation. And why hepatectomy is a feasible solution in this is because here is a patient who is going for a gallstone surgery. So we expect that the patient does not have significant comorbidities which prevents the patient to undergo a major resection. We don't expect underlying liver disease in these patients. And looking at the type of injury, the best scenario in this is to take away the right segment, which has multiple small ducts, and repair is tenuous in this scenario. Whereas the left duct with the extrahepatic component, you can do a good anastomosis. So one scenario is an acute biliary injury. The second scenario is in a established bile duct injury with stricture. Now here, the indications for hepatectomy are much more limited in my opinion. Commonly, it is said that if there is atrophy, hypertrophy, that is one indication for hepatectomy. The second indication, I agree with you, which you said that if there is a vascular injury with intrahepatic strictures, with or without stones or cholangiotic abscess, then that's an indication for liver resection. I don't prefer to do a liver resection in a primary repair, even with atrophy, hypertrophy. The reason for that is, in this scenario, usually the atrophy is because of biliary obstruction rather than vascular injury. And if you drain that segment, you should be able to sort of salvage whatever is left of that atrophic lobe. Also, you have to remember that hepatectomy of an atrophic lobe is not an easy exercise with rotation and changes of anatomy in the region of the hilum. So it's not that if there is an atrophy, hypertrophy, I think I should go in for a liver resection. Only if there is a complex injury with atrophy, hypertrophy, where you are going to try to do multiple duct anastomosis with unfavorable results, therein you would consider a hepatectomy in that situation. So just to summarize, I think the indications are limited for hepatectomy, but are well defined. So intrahepatic strictures or a complex with segmental ductal strictures on the right side is an indication for hepatectomy, especially if it is a recurrent stricture in that situation, wherein a resurgery in that scenario may be very difficult to do.
So in the acute injury setting, if you have necrosis of the parenchyma, then obviously you have no choice. In the established stricture setting, you try to do a repair as if it is possible, as far as it is possible. But if the stricturing process has extended into the intrahepatic sectoral or even segmental ducts on the right side, especially most of these injuries will be associated with a vascular injury. That again becomes so. Just Dr. Anand asked me to show this cholangiogram, a patient which we recently had. If you see here in the middle row on the right side, you can see that all three ducts are separated, right anterior, right posterior, left. They are not joining. So this is the type of a case where left duct you may still get, because we know that left duct, especially when it has a horizontal course, it has a significant length of extrahepatic duct, which you can identify once you lower the hilar plate on the base of segment 4, the quadrant row. But the right duct is very small extrahepatic course, and if the stricturing process has extended into the right sectoral ducts, then it is likely to be intrahepatic, and that will be very difficult to identify at surgery. And these are the type of cases where you need to have, you should have, you must have pre-operative cannulation or catheterization, especially of the right-sided ducts. So Govind, since you are there, suppose for whatever reason you have not cannulated these ducts and intraoperatively you don't find the right duct. So what are the ways and methods to find the right duct in a difficult stricture?
Sir, hepatotomy can be done, sir, in the right side.
Hepatotomy where?
Yes, sir. GB4, one is the right anterior hepatotomy in the GB fossa. Hepatotomy can be done, sir, to expose the right sectoral duct, and from then on progress.
So if you are not able to find the right duct, straight away you will do a hepatotomy. Is there not anything less than that, a smaller maneuver procedure than that?
Intraoperative ultrasound can be of help, sir, if available. Other than that, if there is continuity, we can also try the hepcoinod approach, that is expose the left duct and from there on go to the hilum, and from then progressively expose the, in case it is not, if the continuity is there, we can even drain from the this thing, sir. The left duct can also be drained in case the continuity is maintained.
Can you elaborate more on that hepatotomy? What exactly do you mean? Where do you do it? What is the anatomical basis of that?
Sir, right posterior sectoral duct is just near the GB fossa, sir. So,
sectoral duct lies in the GB fossa, anterior or posterior?
I didn't understand your question, sir.
Posterior sectoral duct lies in the Rumore sulcus, isn't it? The anterior
Yes, sir.
sectoral duct lies in the GB fossa.
GB fossa. Yes, sir.
So, starting from the minimum is that you first identify the left duct, and if you when you open the left duct, if you don't see any, if you see, say, as I said, that suppose it is a type 3 stricture technically because the two ducts are communicating, but the communication is very small. So you may see a hole, you may see the opening of the right duct there, you may see some bile coming from there, and then you put a small mosquito forceps or a fine right angle, and you may enter into the right duct. So first is that. Second, suppose the two ducts are separated, there is no communication. Then in that area, once you have reached the right end of the left duct, in that area, when you see the fibrotic scar, you do a little bit of dissection there, and then you do a fine needle aspiration there. You may locate the right duct if it is lying just close. And all this information you already have from your cholangiogram. That's how much is the maximum separation between the two ends of these ducts. So you have an image in mind as to where you are likely to get the right duct. Then the hepatotomy that you do, it is actually hepatotomy or just a little bit of pouring of. Is indeed. Somebody's microphone is on. So you know that the right anterior sectoral pedicle is running in the gallbladder fossa, and if you make a coring or hepatotomy perpendicular to that in the gallbladder fossa as close to the hilum, then you are likely to hit the pedicle, and in the pedicle, fortunately, it is the duct, unless there is a significant rotation, which will be there. So these are some of the methods before you do a formal hepatotomy, which at least I have not done in any case, described by Dr. Miyazaki and Marquedo from Mexico, that you do a hepatotomy on the anterior surface of the liver and open the liver like this, and then you reach the right anterior sectoral pedicle. Dr. Sadik?
So again, now going back to what Dr. Kapoor asked, that if you don't, so first and foremost, I say that anybody, I mean, all of the people who are training in GI surgery, you should not land up in a situation like that. That means your assessment preoperatively of the anatomy has to be appropriate and err on the side of cannulating the duct rather than facing the problem intraoperatively. So that's the key message from this, that you shouldn't land up in that situation. The second point is that my approach may be a little different. I would get my interventional radiology in the operating theater in order to cannulate intraoperatively the duct. So what I would have done preoperatively, if I have missed and I'm not able to identify, I think it is best to try to get this cannulated intraoperatively with an intraoperative ultrasound and cannulation of this duct. The other aspects which Dr. Kapoor was mentioning, the technical aspects, I think are very important for all students to understand. And what I would like to emphasize upon is you need to have an understanding about the plate system of the liver. So you have a hilar plate in the middle, then you have the umbilical plate which goes up into the falciform ligament, and then you have the cystic plate on the right side, which harbors the anterior sectoral duct. So when you reach the base of segment 4 and you reach the hilar plate, you dissect off the base of segment 4 so that you expose the hilar plate. Now this hilar plate, you can dissect on both sides. So on the right side, when you do, it goes on and lowers the cystic plate. So that's a good plane to be in. And you just dissect the liver off the hilar plate, and you can be surprised that up to about 2 to 3 centimeter in the liver, you can dissect in that plane without any risk. And you will get onto the right ductal system. Of course, it will be the anterior ductal system, but at least you will get onto that ductal system wherein you know that if there is the dilated duct over there, you would be able to reach that. Also, if left duct, you'll always get, it's rarely injured in a benign biliary stricture. So you don't have to get onto the umbilical plate to do that. So basically, hilar plate and cystic plate have to be lowered. In that scenario, sometimes with the little hypertrophy of segment 4, you may have to take off a sliver of segment 4, base of segment 4, in order to expose the hilum anteriorly, so that the hilum is available for you to see in front of you. And if you want to open the duct, then you have enough space to do the anastomosis. So you can do a sort of excision of a sliver of base of segment 4 and also core out the tissue in the GB fossa around the pedicle that you see there. So that is the way intraoperatively I would approach, and with the help of an intraoperative cannulation, you would be able to identify the ducts. And as Dr. Kapoor said, sometimes there is a posterior approach for the posterior sectoral duct, which you, if there is a ruvial sulcus, you know that posterior pedicle will be in that, and you can dissect from there and reach the posterior duct, and then go back or work to your way towards the hilum, and then excise all the fibrous stricture which is present there. I have not myself used, but I think one of the things which we will be using more often now is a ICG cholangiography for identification of the ducts. You have a handheld probe also for ICG detection. So if you have a handheld probe, then you can give ICG intravenous to these patients. You should have a significant amount of time between the administration of ICG to visualization of the ducts. Usually it is said that it should be at least about an hour, and more than that is better. But in some scenarios, you may attempt in the operating table itself to give about half an hour by the time the dye is excreted in the biliary system. And then you may be able to see these dilated ducts and help you to identify them, which can be reconfirmed by aspiration with a fine needle. I think it is a very promising approach, and may come to our help more and more with availability of ICG cameras in most operation theaters.
Can you come in? So, when would you stent a biliary enteric anastomosis, biliary stricture?
Good morning, sir.
Morning. Yeah.
Biliary anastomosis, usually stenting is not advisable for selected cases where there is a significant fibrosis at the ductal anatomy. Second thing, if I have a very small size duct, or else maybe if there is a ischemic changes in that area, or I would do early repair. In these cases, I consider the stenting of anastomosis. Usually, I prefer the external stent, mostly through the transhepatic route, and then second option can be through the from the transjejunal, transjejunum, and through the peritoneal wall. But only in the anastomotic site, internal stent, I would not consider. According to this study from the US Mayo Clinic, they have put this criteria for the putting internal stenting. But study from our institute, Amrita Institute, they didn't find any advantage in the putting the stenting to prevent the stricture, sir.
That is in transplant.
Yes, sir.
That's in transplant scenario. So, I mean, see, the basic thing is that you have to understand the difference between stenting and biliary drainage, or temporary biliary drainage. Stenting, let's talk about stenting. So stenting, if you attempt to do, it has to be a long-term stenting. Long-term stenting is best done transhepatic because most of these transjejunal stents tend to slip away. So you need to, and you have to realize that in an enlarged liver, and especially with non-dilated ducts, to try to place a tube intraoperative transhepatic is going to be very difficult. And therefore, preoperative placement of these catheters is very important in situations where you are contemplating long-term drainage. But the point is clear that if there is long-term drainage which has to be done, it should be transhepatic. How long should be the drainage? Minimum of 6 months, but it could extend even up to 1 year. Then when you should drain it? So you've addressed most of this, wherein there is small ducts in which you have to do. More important than small ducts is that when there is still scarring and there is not a healthy, well-vascularized proximal duct available for anastomosis. In that situation, you may want to stent this scenario. In this scenario, you want to put a long-term stent. So the scenarios are very limited in the way now we conduct this procedure of repair and hepaticojejunostomy. So only in very limited scenarios, complex strictures, segmental disruption of ducts on the right side with small ducts, or you are unable to go very high up because of scarring of these ducts and you have to do an anastomosis. In such situation, you would do a transhepatic long-term stenting. What modification we have done now is that when we have to do the stenting, it is in a very specific scenario where the ductal condition is quite compromised. So we electively do a dilatation of this HJ which we have performed in these patients in a graded protocolized manner. So we start after about 6 weeks of surgery, you dilate with a balloon, the HJ point of this anastomosis, and then you continue to dilate this sequentially every 3 to 4 weeks till about 6 months or 1 year. And basically how you assess is that you see that there is no waste when you inflate the balloon over successive dilatations. And it is not difficult to dilate the stricture by inflation of the balloon. So these two criteria determine that it is adequate dilatation. And once it is done for about 6 months or up to a year in some situations, then we pull out these catheters. So these catheters need not be on drainage all the time. They can be blocked and capped and kept under the clothes. So it is a little discomfort for the patient, but they don't have to carry a bag since it is an internal external drainage catheter. So that is, I think, about long-term stenting. Dr. Kapoor, you want to add anything on?
No, that's fine. Before I ask my colleague Dr. Shashwat to come in, Jaya has asked a very important question. I'll take up that. Do we need to dissect the bile duct posteriorly of the portal vein? No. When you are dealing with a post-cholecystectomy benign biliary stricture, you don't try to do circumferential dissection around the duct because there is a very high risk that there will be inflammatory fibrotic adhesions between the posterior wall of the duct and the anterior wall of the portal vein. And there is a very significant risk of causing an injury. And if the portal vein gets injured, then it will be a disaster. So you don't do unless you have a suspicion that the stricture you are dealing with may be malignant. In that case, yes, you would like to excise the stricture and send it either for frozen section to confirm that it is not a cholangiocarcinoma. Sometimes it may be difficult to differentiate. But if you're dealing with a post-cholecystectomy benign biliary stricture, then the dissection is only to expose the anterior surface of the bile duct and not a circumferential mobilization. Shashwat, you want to come in before we close?
Yes, just one question for sir. With regard to the increased utilization of duct-to-duct anastomosis in transplantation, do you think it's going to gradually translate to a higher number of duct-to-duct anastomosis even in bile duct injuries, and is that feasible? And because the duct size is, recording in progress. Non-dilated ducts, when it's an intraoperative injury and it's a non-dilated duct, but that's the same duct that is also dealt with in transplantation. So, yes. Is that
there are differences? One is that in transplant, you have intentionally, surgically divided the duct. Yeah. Whereas in a bile duct injury, it's an accidental division, unintentional division. Second, in bile duct injury, we must have used a lot of energy. So there is a thermal component of injury also to the duct. Third, that in many cases now in lab chole, we are seeing very high injuries as opposed to what we used to see during the open cholecystectomy era. Fourth, the classical laparoscopic bile duct injury actually involves not only a division of the duct, but an excision of a segment of duct. Because initially, the surgeon thinks that what he or she thinks is the cystic duct is actually the common bile duct, and the right hepatic artery is mistaken as the cystic artery. So they are clipped and divided, and then as you go up, then you encounter the common hepatic duct, which gets divided. So a segment of the bile duct is excised, and trying to do an end-to-end anastomosis may be under tension. There is a report from the Academic Medical Center in Amsterdam on end-to-end anastomosis, not done by them. Patients referred to them after an end-to-end anastomosis. Where the results were not as bad as it used to be thought earlier. And there are some advantages if technically end-to-end anastomosis is possible. One is that you avoid a bile leak and external biliary fistula and bile loss and all its consequences. Second, even if this end-to-end anastomosis is at higher risk to restricture, this is a restricture with a ductal continuity, which is endoscopically manipulable. So you can handle it. What now people are saying and doing is that if technically without tension, end-to-end anastomosis is possible, it may be an option, although the ideal still remains a Roux-en-Y hepatectomy. Dr. Sadiq, any?
No, I quite agree with you. It may be a small proportion which may be feasible for that, and the Dutch studies have shown that, and all the points which you said. We'll just take quickly some of the questions which are there. One question is, could ICG be injected directly to the portal vein or for intrahepatic ductal identification so that for portal vein? I don't know about this. I'll have to look up because direct ductal injection is known, but whether the portal vein will do it early in the bile passage, I'm not sure because it will again have to go to the liver, which is normally done and is excreted out, but I'm not sure. Vishal has, Dr. Kapoor has answered dissect. I think I want to emphasize that because I've seen some demonstrations and videos of surgeons demonstrating bile duct injury repair by excising the strictures. So if it is a benign stricture, no, please don't do, and it has more risks than benefits to do. Also, the proximal duct, you may cause ischemia, and you don't want ischemia of the proximal duct with too much of dissection. So not to do that, only to expose the duct. And Vishal has asked, he's just posed a question that do you keep the transhepatic stent proximal to the anastomosis or transanastomotic? I keep it both transanastomotic, but I make sure some holes are there proximal also. So holes are proximal and distal to the anastomosis.
Now these are the E4 type injuries with the catheter incident, 3 catheters from the right.
Can't hear you. Can't hear you.
I'm audible now. Hello. I'm audible.
See, this was an injury. Sorry, can you hear me?
Not very clearly, sir. It's little.
We had a very high injury, and there was internal fistula between the proximal ducts and duodenum. So, because it was a high injury, as we discussed, we wanted to cannulate the ducts. So, the interventional radiologists, they have put catheters into right anterior, right posterior, left, and all these catheters have gone through the fistula into the duodenum. Now, the debate in our group was that should we consider this fistula as an anastomosis and dilate and stent it, as you said, for 6 months, 1 year, or should we go in and do a Roux-en-Y hepaticojejunostomy? It's
Obviously, it's a difficult stricture because you have put 3
very
catheters.
difficult. Very difficult. In fact, even type 4 duct, segment 4 duct is not seen when we injected contrast through the left. So that duct is still not cannulated.
So I would leave it at that. If you have cannulated and gone through the duodenum, I think that may be still the best for the patient.
It's the same patient which I showed the MR earlier.
Oh, this
Anand
one?
is projecting it again.
Uh-huh.
So it's a very difficult stricture. And one thought in the group was that should we use this fistula now since we are across it and dilate and hope that the hepaticoduodenostomy, which has naturally occurred. So you can see here 3 catheters across the fistula. One has gone proximally into the stomach and 2 are in the duodenum.
I know, but to me it appears repairable, sir. The ducts are not that bad.
They are actually bad because the
cholangiogram.
Yeah,
but I think if you have gone across and got 3 catheters across, you can always see how these things are, how the patient behaves.
Yeah, this is the pre-cannulation cholangiogram. So, in fact, there are 4 separate ducts: right anterior, right posterior, 4, and left. And 4 is still not cannulated. Okay, I think we are already 10:10. So once again, I would like to thank Dr. Sadik for his time and answering the students' queries. But again, I would request students to be more proactive and more participating. You should come prepared for these sessions with questions and answers also. And then the role of the moderator is to only moderate your answer and refine it or make any corrections. But I don't want this portal to be a passive one-way flow. So once again, my request to students to prepare cases, case summaries, to prepare operative. Now, how do you prepare an operative procedure? You make a answer that what are the indications, what is the preparation, what are the contraindications, what is the procedure, what is the complications, and what are the results. And we will ask those questions. You give the answer, and then the moderator will correct or modify you. That is the format that I want. Okay.
All right. Thank you very much.
Thank you, Dr. Sadiq. Thank you, Avinash, for your technical support. Dr. Avinash, my former student from SGPGI, who is now a consultant GI surgeon in Ahmedabad, has very graciously offered technical support, not only for this forum, but also for the Jaipur Surgical Festival. So his technical team has posted all the videos, I think about 25 lectures, which were held in Jaipur Surgical Festival on YouTube. I think on YouTube, if you put Jaipur Surgical Festival or Gastro University, which is the e-portal developed by him, you will get to one of them, these videos, and then you can go on to the other videos. So whenever you have time and you want to watch, please look at these videos. Thank you all. Thank you very much. We'll close.